I'm always humbled by some case that I have where I'm struggling to get a root out, or I'm, I have difficulty doing something, or a difficult anesthetic case or whatever. Inevitably, before I go off to a training, I get to eat a little bit of crow before I go in and tell these people. I mean, there's a reason why they say it's like pulling teeth. I mean, if it was easy, that saying wouldn't be there. But I mean, doing dentistry and performing procedures and performing extractions and cleanings and all of those things, if it was easy, there wouldn't be a whole bunch of rotten mouths out there.
Right now, there is a trend going on most of these early career professionals. They come out and their biggest fear is about getting sued. Is that a trend that is just recently started, or is there another trend that concerns you?
I felt like my first day of orientation was that you're going to fail out. And then the second day of orientation was, well, if you don't fail out, you're never going to pass boards. And then I felt like third day of orientation was like, well, if you fail, or if you don't fail out, if you don't pass boards, somebody's going to sue you. And then I felt like then the next day was, if you don't get sued, you're going to be in so much debt that you're going to be, having to work for the rest of your life to overcome all of your debt. Looking up, why clients are upset when adverse events occur. And it's never really because of the adverse event. It is because there was some sort of a breakdown in communication. Something, maybe it wasn't explained to the client, the complications that could have happened, or maybe it was a cost issue, or, maybe it was, something that was unforeseen. But, being honest with clients, have I left roots in dogs? Absolutely. And I've told the owner that I felt like I was doing more harm than good to try to retrieve it. And I've not had an owner be upset about that because I was honest with them. And I felt I was doing what was right in the best interest of their patient.
Have used your 3Ds a lot. I love that, of general practice.
Derm, dentistry, and diarrhea.
Oh my gosh, 1000% correct. Mm-hmm. That is so awesome. Do you use that a lot when you teach your students?
Yeah, I mean, well, that's what we try to, to talk to them about, especially within the primary care facet. Like we look at, what are the reasons that you're most commonly going to come in for care versus just the regulations of having to do vaccines and things in that respect. And it's always left with derm, dentistry, and diarrhea. Like I just went to go find my lanyard out in primary care land, and they're like, hey, you want to look at this loose tooth? And that was like, they were the only people that were in there. So I'm like, well, you didn't come, but you still need me.
What was it? A loose incisor?
Yeah, it was a small breed dog. So, I mean, it could have been a number of loose things in all sorts of places for sure.
Yeah. Well, I definitely want to talk about, because I've had some new grads on here.
Yeah.
And there's a common theme of lack of confidence when it comes to dentistry, extractions, and all that stuff. And, just how it leads to more of the stress of the profession, especially since it's one of the 3Ds. I mean, there's absolutely no way to get around it. If you're going to do general practice, you need to do dentistry. And yeah. I'll have you know, like I'm doing my relief shifts and I'm choosing all Banfields because when you're in the fourth quarter of your career, Banfield is the place to be. I'll tell you that right now. I don't know how people who are just starting out are going to Banfield because I don't know how much you'll truly learn that way.
Oh, sure.
But I mean, something comes in sick. You run diagnostics and x-rays because they've already paid for it. You don't even really need to discuss cost. And then you ship them to a VCA.
Oh, sure. Yeah. Yeah.
I'm like, this is awesome.
Right. No doubt.
Oh my gosh. And my wife is like, because she's retiring the 29th. And I told her, well, it's not because she wants to retire. It's because she can't handle the up and ups that have bought the practice.
Oh, sure.
And it's getting worse by the day. There was a euthanasia that came in the other day, and they had the darn thing sedated for 3 hours because they couldn't hit a vein.
Oh, wow. Okay.
I'm like, well, what about IP? What about
Yeah.
intracardiac? What about a
Yeah.
jugular? I mean,
Yeah.
there are ways to do it
For
that are
sure. Yeah.
humane.
Absolutely.
I mean, I'm on the owner's side on this one. I'm like, what the hell, you
Yeah.
know?
Well, yeah. And it's, you already have a client who has enough angst about, euthanizing the pet, and then it takes that long. It would be different if it was the client not being able to let go or make a decision. But when it comes to be the inability for us to provide the care that those animals need, that is where things, go awry, or can make or break a relationship with a client. I tell the students all the time too that, one of the moments that I remember as a fourth year student is I was euthanizing a dog that I had cared for while I was on my ICU rotation. And I didn't, unbeknownst to me, the client was a practitioner, and I euthanized his dog, kind of talked him through it, did all the things, and he offered me a job right after I confirmed that the heart was dead. And I'm like, wow, I mean, it was weird because of the fact that I, didn't expect that, and I didn't, realize that he was a doctor. But then, I mean, that was very impactful for me, to be, at his lowest with grieving about this client, and or grieving about the loss of his pet. That was
Yeah.
when, it was impactful what I had done to then enough for him to offer me a job, which was
And I
weird.
think, well, the problem is I don't think veterinarians, it's a human trait, probably. I don't think as veterinarians we really look at how wonderful clients can be.
Hmm.
We don't remember that.
Yeah.
I mean, the fact that you remember that from your fourth year rotation amongst Lord knows how many
Are you saying
things
I'm
you've
old?
seen.
Are you
No,
are you saying I'm old? Because that's what I'm hearing from
no,
that.
I'm not. I'm not saying you're old, but I'm just saying we lose our memory once we hit 32, and you're what, 34?
Exactly, exactly. I'll
No,
just
but I
stay
mean,
that age forever,
right? We forget those things. We
for sure.
totally forget them, and it's so easy to it would be just so easy just remember the good things and forget the bad things, but our
Yeah,
human nature, I don't know if
just
it's
remembers the
because
bad.
yeah, because we're
Yep,
perfectionists or we're competitive
yep.
or
All
what
my
it is.
inadequacies. Yeah, I mean that's one of the things whenever, and it's always nice and terrible at the same time. But before I go off and do a training, inevitably I'm always humbled by some case that I have where I'm struggling to get a root out, or I have difficulty doing something, or a difficult anesthetic case or whatever. Inevitably, before I go off to a training, I get to eat a little bit of crow before I go in, and tell these people. I mean, there's a reason why they say it's like pulling teeth. I mean, if it was easy, that saying wouldn't be there. But I mean, doing dentistry and performing procedures and performing extractions and cleanings and all of those things, if it was easy, you know, there wouldn't be a whole bunch of rotten mouths out there.
Well, the fact that you said you were humbled, that you still get humbled by some of your
Sure,
cases,
absolutely.
um, is there like an uncomfortable truth that we don't realize until we get into practice about dentistry?
Well, if I were just going to say that there's an uncomfortable truth, every case is unique, and without the tools that we have, as far as from a diagnostic standpoint, instruments that we have, all of those things, and even if the best laid plans are out there, it doesn't mean that things still can't go wrong. And yeah, as practitioners, yes, that's, as a general practitioner, as a specialist, I think, it is not an easy job to do, or to be a veterinarian, but to do appropriate dentistry and dental procedures, how, providing the care that we are doing. I mean, you have to have the tools, you have to have the knowledge, and you have to have the skill. The problem, I think, goes to the fact that as a general practitioner, you have to be a jack of all trades, and you have to, and then that allows us to not be a master of any, because of the fact that we have to know how to do the anesthesia, but then how to put the nerve block in, but then how to fix the equipment when it doesn't work, to, how do you extract the tooth? How do you close it? What's the suture material? And you have to couple all of that with the fact that the animal is renally insufficient, it's hypotensive, and it has a heart murmur, it's hypo or hyperthyroid. How are you going to fix those and balance what is right for the animal and what should be done? And I get the luxury of sitting here in my ivory tower where I have a whole group of people that does all those things, and I do get to just focus on this one area. But even when I focus on that one area, sometimes I still have bad days, and I still have times when I'm breaking roots, and I still have times where things are a struggle, for sure.
Oh, the breaking of roots.
Yeah.
That's it. Actually, that's a great name for a podcast.
The breaking of roots. Yeah, no doubt. No doubt.
Oh,
I usually tell people I save lives one tooth at a time, and sometimes I lose a lot of lives. So like that's the biggest
well, okay. So have you ever had to have a quality of life discussion because of a dog or a cat's or an animal's mouth?
For sure. Yeah. When we look at it, I think that, you have to look at the cost to risk benefit ratio. I think everyone always has a story of my cousin's uncle's brother's girlfriend's twice removed had a dog that died because of a dental cleaning. And I don't think that that's true. I think that there are things that surrounded that situation, in which, was the animal worked up to begin with? Did it have an underlying cardiac condition, or, was it too hypotensive because we didn't monitor it, or, something happened, but it wasn't because of the quote unquote dental procedure. But I think that it gets a little bit confusing, because a lot of times the dental procedures, if they're done in a general practice setting correctly, they should have them at least once a year. You go to your dentist once or twice a year, every 6 months. That's usually what our insurance pays for. And if you go by the year, by the, one dog year or cat year is 7 years, or whatever the formula is now, and you get them in every year, that means that you're cleaning your teeth, or their teeth, every 7 years. And if we didn't clean our teeth every 7 years, and didn't brush our teeth for 7 years, and didn't floss our teeth for 7 years, we'd have a pretty gnarly looking mouth as far as that goes. So, I think that, trying to stress to the clients and trying to stress the home care, if we wait 7 years before we do that, we are already behind the 8 ball. We already have a trash mouth. But if we do them every 6 months, then we're maintaining what is there. So we're scaling all the plaque and calculus that is off, that's accumulated in the past 6 months, and we're not playing catch up by kind of doing the pluck and chuck and just removing all the wiggly teeth
without dental radiographs. That's my personal favorite, right?
Yes, for
now,
sure.
I understand if you have, like, let's say that 14-and-a-half-year-old miniature poodle that has just a bridge of tartar, that's the only thing keeping the teeth in the mouth, just start pulling. That's if it's going to make the dog better. I always used to tell my associates that I was there, I was like, just try to get that calculus off, and if they're loose and they're really loose, just we'll do post-op dental x-rays, because there's like no reason you should be able to pull a premolar 4 out just push it out with your finger.
Yeah, I like to call that a calculus splint.
Oh my gosh, I never thought of that.
Yeah, it's like a calculus splint. That's the only thing that's holding those teeth in the mouth, for sure.
I know. And and it's so amazing when clients, it's like you educated them enough that they understand the importance. I don't want to say you convince the clients to do it, because you actually aren't convincing them. You're educating them enough that they are able to make that educated decision that this is really important. Those animals go home feeling so happy.
Yeah,
give them a couple days of pain and all that, but once they're healed, if they're like, oh my gosh, I got a new dog.
And that's what I try to always talk with the owners about, because of the fact that, if I do have a patient that has a tremendous amount of comorbidities that I truly feel like it's not in the best interest, I am not a salesperson to try to convince them to do it. That client has to be committed, because those are the cases in which they need to want to do that procedure, and I can, go in there and do it. We recently had one in which we put in a pacemaker to take out or to do a dental cleaning. We put in a temporary pacemaker because the client was committed, and they, are like, we want to clean these teeth because obviously the oral cavity can um, cause the issues with the cardiac disease, and it's a downhill kind of a waterfall effect, right? So if we end up having to clean the mouth, we can maybe stay off some of that cardiac disease. But the owner had to be committed, and they had to be committed to then following up and doing dental home care and following up, because that's obviously a huge financial investment, but it's also a investment in the patient as well.
I also, because obviously I'm doing relief work here and there, and I'm still reading in records. And I want to get your take on this, because obviously, with what we're trying to do is we're just trying to educate, the early career professionals. And if the older career professionals can learn a new trick, that's great too. But you always read in there about, endocarditis and all this other stuff. Which one is worse, the bacteria showering or the chronic immune stimulation you get from a bad mouth?
For sure. So, the question that I always ask the students is how long does it take from the bacteremia from a dental cleaning to be cleared from the bloodstream? So, what's your guess? Unless you know.
I would say, because no one really recommends antibiotics anymore after a dental, I'd say it's pretty quick.
Yeah. So it's about 90 minutes. I mean,
Mhm.
as far as, and it doesn't matter how terrible the mouth is. And it seems like that the bacteremia that you have from a dental cleaning is the same bacteremia that you would have from having a bowel movement, chewing, brushing their teeth. So we're constantly just showering ourselves with bacteria in the oral cavity. So when we have these cases, I don't really think that there's a cause and effect relationship. Like, I don't think if you have a bad mouth, you therefore have cardiac disease or endocarditis or any of those things. Do I think that it could set up for a nidus? Yeah. I mean, I do think that if you keep the oral cavity clean, I do think that it is less bacteremia to shower the kidneys, to help shower the kidneys, to shower the liver, to it could exacerbate your diseases. We know with the cats and dogs that are diabetic, we clean up the mouth and suddenly their insulin requirement decreases. So there is some sort of an inflammatory component, but are they truly cause and effect? I don't think so. I mean, we also recently had a cat that had, it was renally insufficient, it had cardiac disease, and then we did blood work, and it ended up being hyperthyroid. And I'm like, let's postpone the dental procedure until we can get the thyroid under control. Then we can do it. So we have a better, more stable anesthetic candidate. And I think, being cautious, I'm way more cautious. I won't push through for that. We'll figure out a way to get you rescheduled, to get you in to do the procedures. But I'm definitely not a strong arm to push things until we can have a stable patient.
Yeah, that what you said about diabetes, you know, when it comes to ketoacidosis, that's one of the things you got to look at is dental disease, right?
Right.
Urinary tract infection, pancreatitis, Cushing's. There's always something that pushes a diabetic over the edge,
For sure.
and it's amazing. One of the internists that used to do mobile ultrasound out here, she would have me clean the teeth on all the kidney failure cats,
Hmm. Yeah.
and the kidney values would get better.
Right. Absolutely. Yeah. All those
That's
inflammatory mediators
correct.
are just in there in those rotten, trashy mouths.
Yeah, I mean, it's like, people. It's so funny because you hear people like, "Oh, I don't want to vaccinate my dog," but they let the mouth get awful.
Hmm.
And like, what's the difference? You're both of them are stimulating the immune system the same way. At least a vaccine is a spike, and then it goes back down. Where a chronic mouth is a chronic immune stimulation that never shuts off.
Right. For sure.
So yeah,
Absolutely.
that's really interesting. Okay, I let me get a little bit into your history. Where did you do your veterinary education at Iowa State?
I did. So I got my bachelor's of animal science, and then I had applied for veterinary school for, during my sophomore year because I was able to get in high school some college credits transferred. So I applied during my sophomore year of undergrad, my junior year of undergrad, and then my senior year. I'm like, gosh, I probably need to do something with my life if I don't get into vet school. And so I had went and interviewed at the Ohio State University, and I was interestingly going to do a master's in beef cattle reproduction. And then near where I am, there's a small community college that is very ag oriented, and my thought process was that interestingly, I was always going to teach in that respect, so I was going to try to go there and teach with you know some sort of facet of ag medicine and animal science. And when I got back from Ohio, there sitting in my mailbox was my acceptance to veterinary school. So I'm like, waive tuition and get paid, or go in debt and do what I've wanted to say that I was going to do for the past 3 years. So I ended up accepting going to veterinary school, and then graduated from Iowa State. And I was in private practice for about 6 years, kind of in Chicago suburbs, and a small animal practice, and then a mixed animal practice in Iowa, and then an urban practice in around the Des Moines area. And there was an opening at Iowa State in the primary care facility, and I'm like, well, I would really like to see what this would be about, because for me, private practice was always missing something, and I feel like it was missing that educational aspect. And so I got the position of primary care, and it was kind of written in my contract. They wanted me to become board certified in something. And so I chose dentistry because I feel like it was something in school we didn't really get a lot of education on. And I wanted to make a difference. I wanted to, give back to the alma mater, give back to the profession, and make the students' lives a little bit easier than what I had it when I was first in practice. So I started a dual appointment with the University of Wisconsin-Madison. So I spent the even months of the year in Iowa and the odd months of the year at UW-Madison for 4 years to get my 2 years of credentialing. And then the third year, they kind of just kicked me out of the nest and said, go back to Iowa. I went back to Wisconsin after kind of at the end of my quote unquote, I guess it would be my 5th year, since it was the 4 years to get the 2 years. And went back to Wisconsin, studied for the exam, took the exam, and then came back to Iowa State and kind of started in the primary care. And then we broke off, where I had a dental rotation for the 4th-year students for a little while, and then COVID ruined everything.
Yes.
And I ended up recombining back with primary care, because that was also around the same time that the COE, or the Council on Education, came out with Standard 9, in which there was a requirement to provide hands-on and didactic training in dentistry. And so we recombined with primary care, because our primary care at Iowa State is a required rotation. So that allowed me to get at least give all the Iowa State students and the visiting scholars and our kind of UNL scholars as well. They could all have an extraction wet lab through the primary care service, since it was required. And I guess I've been here ever since. So I've been at Iowa State now for 17 years.
So is dentistry an elective rotation they can take their
Well,
senior year, or is it a core?
because it is just me, when we recombined with primary care, the dental rotation itself went away. So primary care and the dental education through primary care would be core, as far as for being a core rotation.
Gotcha. Yeah, because at Illinois, Dr. Manfra, it was an elective
Yeah.
rotation.
Yep.
And she'd be walking around with 7 students right behind her.
Yep. Absolutely. Yep. Well, and Dr. Manfra also still supports and delivers an online dental course for those schools that don't have a instructor who is at least educated in dentistry. So that I believe is still an option for for numerous schools out there, and especially the island schools and things like that too, to at least give some foundational information. They don't get the hands-on, but it at least gives them some of the foundational information of what's important to know with regarding dentistry.
So you said primary practice was missing the educational aspect. Was that because you were not getting mentored? You wanted to mentor, you wanted to teach, you wanted to get into research? Like what was the missing link when it
I
came
think
to
for
work?
me, it was, I mean, I always spend a lot of time in rooms with clients, so I always liked that educational facet just so everyone was in the same place. I think for me it was that kind of almost that higher calling of being able to teach others or other professionals more so about veterinary dentistry to make their lives just a little bit easier and kind of come off with little things to help them remember some of that information. And for me, I think it was I did have really good mentorship in the first practice, that I was in, and that's kind of why I chose it. It was an AHA practice in which there was two graduates from Illinois, one from Kansas, and one from Iowa State. And, so they all had different ways to practice. There was different age dynamics. And I would be like, oh, I have this dog with diarrhea. And I'd go to Dr. A, and they would be like, this is how I treat it. And I'd go to Dr. B, and they'd be like, this is how I treat it. I'd go to C, and they're like, this is how I treat it. So it was allowed me to really have that, that autonomy to kind of choose how I wanted to practice. And it was a very, very good experience for me. And of anything, I think a lot of times veterinary students, as they're looking for jobs, or early career veterinarians, they are just looking to make money, and they don't pay any attention to the mentorship that they can provide. And that being said, I'm fairly anal retentive, and I know that I had a complete spreadsheet that's for each practice that I interviewed that said, do you have this equipment? What is your mentoring philosophy? And I would talk to the doctors there, and I would talk to the receptionists, and I would be like, if you could change one thing about this practice, what would it be? And inevitably, whatever answer they gave would be the same issues that I would have with the practices. So, I mean, I think it is very important as early career veterinarians to be able to express what they need, and what kind of guidance are they going to get. We've all had the horror stories of, I walked into practice and the owner handed me the keys and said, peace out, I'm going on vacation for a month, or I have to get this CE, otherwise I'm going to lose my license because I haven't been able to, because I've been looking for someone to fill this spot. So I think it's very important to have that understanding with whatever clinic the early career veterinarians decide to know that they still need that guidance. Veterinary school is like drinking from a fire hydrant. So you get all this information, but no one tells you how to turn off the fire hydrant and slow down the flow so that it can be absorbed and then it can be delivered again.
How did you feel your dentistry was your first few years of general practice? Looking
I
back.
Yeah, no, those first few years, I learned everything from a technician. I'm not even sure that I graduated veterinary school ever having extracted a tooth. We did have an incredible surgeon who had interest in dentistry, and she provided our dental education. But with that, there wasn't really the opportunity to be able to get any of that hands on. So a foundational knowledge I had, but the actual practical, the hands-on stuff, most of my early years were spent watching a technician extract teeth, and watching them deliver the stuff that I should have known how to do that I didn't know how to do.
Were they doing dental nerve blocks back then?
They were not, for sure. No. Yeah.
Yeah, I remember the days of medicine, which is, oh no, you don't really want to give them many pain meds because you don't want them being too active when they're done with
Right.
surgery.
Sure. Yeah.
And I
Yeah.
think it was Dr. William Tranquilli at Illinois that figured
Sure.
out all the hormonal imbalances that happen
Yeah.
when you don't give them pain meds.
When you don't. Yeah, exactly. For sure.
And it's weird how And even then, though, even though we knew all that information, it still took forever for it to evolve to where we are now. And that's one of the biggest arguments I have about this profession is that we are so slow to change, even though we know something is newer or there's new information.
Yeah,
We change how we do. We don't want to change how we do things.
right, for sure.
Working with students, what's during their senior year, when do you see fear start setting in, and
Uh, it,
how
it,
do you block that?
well, I mean, it's hard, and it's always individual because they're very excited to finally get into the clinics in May, and and they want to be able to do things, and they want to be involved, and they want to do that stuff, but they again, they have a lot of knowledge, but they just don't know how to apply it or where it goes. And then we kind of hit around the fall now, and now there's multiple times, but fall, then they get so very highly focused on just trying to pass boards. So they again are sometimes don't take as much opportunity to do the hands-on things because they're like, I need to get this other step done, I need to pass boards. And then I think that they focus a lot of times on um, passing the boards and passing that didactic portion of everything, and then they're exhausted. And then they we come to the kind of the winter spring, and then the panic sets in or the apathy sets in. That's kind of what we see, because they're like, well, we already know these things, we're just biding our time until
Going through the motions.
going through the motions so that we can hit that May timeline. And then I see them, either start to panic or panic right afterwards. And I get a lot of emails about, I saw this case and I don't know what to do with it. And we're like, well, we did discuss those cases.
What is that, June?
Yeah, exactly. That's exactly right. Yep.
Yeah, well, no, I found it very important for me, for at least personally for myself, to have great relationships with uh the professors and clinicians at Illinois, because
Yeah.
I knew I would probably need them at some point,
Yes,
until I made that shift into practice, and then started building new relationships with local specialists and like things like that.
for sure.
um when you look at, are there some students that walk in May and you're like, I don't know how the heck that even is possible? And I don't mean that in a mean way.
Yeah. It is sometimes, what I feel is it's almost more of an administrative type of concern with a lot of things, because to run teaching hospitals, and teaching hospitals anymore are kind of becoming dinosaurs, where there's more of the distributive model, in which they farm them out to the teaching hospitals, and teaching hospitals are expensive. They're expensive to run. And unfortunately, the compensation from a university standpoint versus a private practice standpoint or a specialty standpoint, the comparison is there is none, because private practices can effectively pay people better. So then you're left with the people that truly have the desire to teach, that sometimes get a little bit more frustrated with kind of the economy of things. And I think it's hard because our job, we keep adding more and more and more students, which then dilutes out the individual students' experience, because of the fact that they don't get as much hands-on as we would like them to. When I went through, like, even our surgery rotation my junior year, we had terminal surgeries, and we did splenectomies, we did diaphragmatic hernia repairs, we did nephrectomies, and we did gastrotomies, intestinal resection and anastomosis. Like, we did all of those things. And then the shift, which I understand, the shift of the animal welfare and things in that respect. But then it also takes that experience away. So many of these students are doing those procedures for the first time out on their own, without that support blanket of having someone there beside them to be able to help them navigate those experiences and the real tissues. So I feel like the addition of more students kind of dilutes out the individual student's experience.
And what's your opinion on let's just open up more vet schools, because that's how we can take care of the veterinary shortage?
Well, I think that they're opening up the vet schools, but they are most of those openings of the veterinary schools do not have a teaching hospital component. So then they're either farming them out to universities that still do have teaching hospitals, or they farm them out to general practitioners. And not that that is a bad thing, but they may not have the experiences of what the specialists have to teach the gold standard. Like I referenced it earlier. I sit in my ivory tower and I just focus right on here, and general practitioners have a lot of things to focus on, and I think it makes it difficult to then try to teach at the same time, and to try to increase and keep the doors open in that practice.
So is my thinking wrong? When you ship out students to general practices in the local areas, you lose, I think you lose institutional control as far as how they're being taught and what they're being taught and what quality they're being taught.
For
But
sure.
also they're being taught by probably GPs that are having their own mental issues as well.
Potentially, yeah. I mean, I do think that you run that risk of that, or the ones that kind of, with not only is there the veterinarian shortage, but there's a technician shortage. So are they using the students in that respect as free labor? And maybe that's okay for blood draws and catheter placement and things like that. But it's I don't I just you're right. You lose that control of the you lose control over what is being taught and how it's being taught, and are you being taught the kind of the shortcut methods of and looking at things, which sometimes does work but sometimes it doesn't.
Yeah, because I'm thinking, like, when I just was thinking as you're talking, it's like when you are a little small mom pop place, and you're making this whatever, it's like a cake, right? And it really takes off, and all of a sudden you hire a co-packer to start making all these cakes. You lose the control of how they're being made, and then you can lose the quality of it. You could
Hmm.
lose the consistency. You can lose a bunch of things.
For sure.
Um, so yeah, it concerns me. Like, again, there is a difference. There is a difference between Ivy Tower and GP. There is a complete difference. But I think from a learning aspect, for at least me personally, I enjoyed learning the Ivory Tower because I knew that was the best of the best. But then I also knew there were certain things that I would be able to do myself without having to go to the Ivory Tower way.
Well, I mean, I do agree, and I mean, you kind of lose that quality control, and if you're taught the gold standard, and then you can find ways in which you can make the gold standard maybe the bronze standard, and or the silver standard that still works. And I think that that's really important. And I think that the other factor is even as most of us academicians, none of us were taught how to teach. Like we had either an innate ability or a desire to deliver information to other people in whatever way that is. But I think now you've spread that out to a whole bunch of people, and do they truly want to uh, teach, or are they forced to teach because of a a corporation is telling you you need to take these people in and you need to do this thing. Do they want to? So then, and then that opens up a whole political
Yeah.
conversation about well-being and discrimination and harassment and all the things that go into it, that we as academicians are we have to follow the university standards for this, for harassment and all the different things that we have to go to.
But I come on, there's no politics at the university level.
That's right. That is very true. It's
we're,
so
we're
true.
the universities are there for the students.
That's right. They are. And it's there for to honestly protect the students and in
Right.
many and in many situations, for sure.
Because you say, I well, maybe now it's the obviously the salary, but I remember dealing with all the researchers and clinicians when I graduated in 2000, and they were all bitching about the politics and the fact that they had to do research to keep their job. because there are a lot. That's the one thing. Maybe that's why my senior year was so great, is that most of the clinicians were there because they wanted to teach. They did
Sure.
not want to do research.
And
And then the worst professors I had were the ones that wanted to do research and could care less that they would ever teach, but they were forced to teach.
right, yeah. And I think it's different. And Iowa State is very good in that respect, that we have something that's called our PRS, or our position responsibility statement. So we work with our department chairs to be like, hey, I really want to do a lot of teaching, so therefore a high percentage of my time is spent doing teaching, or I really want to do research, so I can navigate that my a large portion of my PRS is doing research, and then I'm getting grants and I'm doing all of these things. Or I really just want to be on clinics. I want to see cases. I want to work in the hospital, and I want to show these guys how to actually be a veterinarian. So then we have that professional practice portion, if that's where your forte is. So Iowa State, we are all supposed to do some sort of research, or have some sort of research component to all of ours, but that could be collaborative. I work a lot of times collaboratively with the primary care. We find the healthy controls. We're doing a collaboration with oncology right now, where we find them the healthy control for whatever oncology project that they're working. Or we find derm good ears, or all of the things in which we are trying to navigate and work together. And then it kind of is a share the wealth type of situation.
I would say right now there's a trend going on most of these early career professionals. They come out and their biggest fear is about getting sued.
Okay.
Is that a trend that is just recently started, or is there another trend that concerns you?
No, I mean, that is not the one that I think of. I think
Okay.
of I mean, I remember that's what I felt like my orientation was. It was like the I felt like my first day of orientation was that you're going to fail out. And then the second day of orientation was, well, if you don't fail out, you're never going to pass boards. And then I felt like third day of orientation is like, well, if you fail, or if you don't fail out, if you don't pass boards, somebody's going to sue you. And then I felt like then the next day was, if you don't get sued, you're going to be in so much debt that you're going to be, having to work for the rest of your life to overcome all of your debt. And so that's what I remember kind of just thinking about. Like, those are like the earmarks for what I thought. And it's I think in general society is has gone away from trying to live within your means, and in trying to you know get the education that you want, have communication, and develop those good communication skills with your clients and your coworkers, to try to help navigate most of those situations. And above all, I mean, be honest. I just was looking up, why clients are upset when adverse events occur. And it's never really because of the adverse event. It is because there was some sort of a breakdown in communication. Something, maybe it wasn't explained to the client, the complications that could have happened, or maybe it was a cost issue, or maybe it was something that was unforeseen. But being honest with clients. Have I left roots in dogs? Absolutely. And I've told the owner that I felt like I was doing more harm than good to try to retrieve it. And I've not had an owner be upset about that, because I was honest with them and I felt I was doing what was right in the best interest of their patient. So, I mean, I feel like that most everything in life, whether it's our personal relationships, whether it's our professional relationships, whether it's our relationships with clients, all boils down to communication, and being able to have clear, concise communication with one another, so that we can all be in this together and get our jobs done.
So let's have some fun.
Okay,
What You know how busy general practice is.
absolutely.
Is there an If you had to do a 60-second oral exam, how would you do it?
If I had to do a 60-second oral exam, angry or not angry patient?
It's not a Chihuahua. Let's say it's a golden.
It's a golden. Okay. So when
Chihuahua, you could do sedation and then you can take your time.
well, actually, I get a lot out of a muzzle. I'll like throw a muzzle on and I just pull the lips back, from there. But so if I'm doing an oral exam, like this is probably the primary care portion back of me, but the last thing that I ever look at is the oral cavity. So I start out by looking at the eyes, I look at the ears, I feel all the, kind of facial-esque lymph nodes move into prescapular, and then feel the belly, listen to the heart, do my rectal, and do all that stuff. And then I go back to the oral cavity. Because for me, every other area has to check out. I'm a side piece. Like the oral cavity is a side piece. Everywhere else has to check out before I even remotely get into the oral cavity, because I want to make sure that that patient is going to be healthy enough to undergo anesthesia. When I go to do my 60-second oral exam, I, look at the front of the mouth to kind of try to check the occlusion. I look at the sides and I compare right side to left side to see, is the calculus deposition symmetrical or is it asymmetrical? If it's heavy on one side, then that's the side that I suspect that there's something that is uncomfortable. If they're even, then they're either equally comfortable or equally painful. And I try to take a little bit of a tally of the missing teeth, to see if there's any grossly missing teeth or at least clinically missing, knowing that I'm going to get my radiographs at a later point. And then the last thing I do is a big open to make sure that there's not some big, huge, gross mass that would be in there or something under the tongue or whatnot. And then I'm off.
It's amazing how many veterinarians forget to check under the tongue.
Yep, for sure.
Yeah, and that's especially if you got a linear foreign body, check under the tongue.
For sure.
So you always check under the tongue.
Absolutely.
What's the biggest misdiagnosis you've seen with dental rads?
Biggest misdiagnosis with dental rads. I think a lot of things are over interpretation. As far as we looking and thinking that there could be some sort of a periapical lucency or an abscess tooth. For me, there has to be other things that are going on. I realize now we unfortunately at Iowa State don't have cone beams, so I know that a lot of general practitioners can give you that 3D image, which is definitely going to help to diagnose some of those. But I feel like a lot of people look a little bit more at think that something is an abscess when it's not. Finding normal pathology that they think is anatomy normal anatomy that they feel is pathology. We are playing the wisdom tooth of knowledge that I call, which is basically like my version of Dental Jeopardy. And I put up an image and I said, what is this lesion or structure? And it's of a mandible, a rostral, somewhat rostral mandible right behind the canine tooth. And inevitably everyone says it's an abscess or it is a cyst, and it's the mental foramen. And I have had or RDVMs or general practitioners that have referred for me to extract that tooth, and then I would knock them out and there's nothing wrong with the tooth, and I'm like, actually it's a foramen. So we talk about how can you tell anatomy from pathology. So we talk about, look at the other side. If the animal has the other side, it's its own control. You can probe the area, but that's not really going to get us much. But redirect your radiographs, elongate them, foreshorten them. If it goes along with where the tooth is, that's more likely going to be pathology versus anatomy. If it goes away from it, it's more likely going to be some sort of an anatomical structure. So a lot of times we take a different view. Look at a skull, see if there's something else that is there that could resemble what you think it is resembling at that point.
Do the words, it's just a slab fracture, don't worry about it, make your skin crawl?
It makes me a little twitchy, for sure.
Okay.
I think the other thing is that so I would tell you, as probably much to my veterinary dental friends' chagrin, I'm not into hierodontics. I don't want to save teeth just for the sake of saving teeth. If I have a patient that, has a complicated crown fracture, a slab fracture with an open pulp, it doesn't have to have a root canal by any means. I mean, it can be extracted, I think that, as long as we treat it in some way, shape, or form, I think that's the most important portion of it. For me, fractures that go below the gum line, which most of those upper fourth premolar fractures do go below the gum line. Mother Nature wants to attach that gingiva back to the bone, not to the tooth. So they're going to be periodontally compromised. So unless you're really into periodontics to recreate the bulge of the tooth and to do things like that, that tooth is eventually going to end up in somebody's sock drawer because of the fact that it's going to be periodontally compromised unless the owners are committed to brushing it every day and bringing them back in every 4 to 6 months for dental cleanings because of the fact that they are periodontally compromised within themselves.
And hopefully it goes into the sock drawer in 3 clean pieces.
3 clean pieces, that's right, especially that palatal root for sure.
Oh my God, the palatal root. Yeah, that's the one. That's the one that gets you. That's the other ones are what they are. And that's the thing I also hear from early career professionals. Again, with the slab fracture, obviously, let's say you have a 4-year-old dog, very healthy teeth, and has a slab fracture. Yes, that extraction is going to be hard as crap, right? There's no other way to go about it.
Yep.
How would you walk them through it, though? Like, how do you make them understand that this is not as bad as what you think it's going to be?
For sure. I think that the biggest thing, and when I teach the labs, and I teach extraction labs, the biggest thing is I think you need to, remove bone, and I think, making sure that your section is complete between front to back, identifying that there truly are 3 roots, even though that palatal root looks like just little tiny nub. Make sure that you have completely sectioned the 3 roots independently so that you can see and you can move them all independently before you start to elevate. I think the other thing is especially after you removed the buccal root, removing the interradicular bone, so the root between the buccal root and the palatal root, because you're in essence just removing the roots out of the same socket. If you've removed your buccal root, you know how deep the palatal root should be. Remove that bone in between there, and then try to kind of put your elevator in between the hard palate and that tooth to try to elevate that tooth out of the same socket.
Yeah. Do all fractured roots cause abscesses and problems in the future?
No, they don't. And again, if you feel like that you're doing more harm than good, or you feel like that you might be at a point where you could push that, root tip into the nose, just stop. Just stop, radiographically document it, tell the owner, and you can watch it and monitor it, or you can refer to a specialist to try to remove the root. I have a little cavalier that comes to see me, and we've been watching and monitoring a maxillary first molar root for about 10 years now, and it looks the same as it did the very first day that I radiographed it to find it. So they don't.
Except the murmur's now 4 out of 6.
No, it is. That's why they come here. Yep. She also has some syringomyelia, so she's very much for her breed standard. But yeah, her mitral disease and her syringomyelia, that's what makes her come to us.
It's a twofer when they go to Iowa State.
That's exactly right. Absolutely.
Yeah. What are the biggest mistakes we make as clinicians when we talk to owners about dentistry? Because now that I'm doing relief work, I feel as if we almost guilt trip owners into doing dentals. Like, I see perfectly good teeth, in my opinion, like a cat that's 1 year and 2 months old coming in for a dental. Do you think we're over promoting it or guilting them into it, or is that you don't have a problem with us doing it? Because I was always trained that sometimes you could do more harm than good.
Well, what I would say is, following the AHA standards, and the AHA standards, say that any animal that is, over, or less than 20 pounds is going to need more dental care than an animal that would be over 20 pounds. what we tell the students is anytime that there is visible calculus on the tooth surface, that is kind of when you want to start doing these procedures, because then again, it kind of goes back to what I said earlier in the hour of you're not playing catch up then. So you are, doing your superficial cleaning, making sure everything is clean. Then the owners can go and, continue on with a the home care if they're able to provide that and kind of ward off the evil. I have a client that comes to me from Minnesota, and it is a 14-year-old miniature poodle, and I think they brush the teeth twice a day, and it comes to me every year, and sometimes I send them away because there's no real visible calculus on the teeth. And I think that dog has maybe only lost 7 teeth in its 14 years, which is pretty amazing for a dog that weighs like 8 kgs. So but so dental care does help. Dental care is something that should be provided. I would say on the opposite side of that, I feel like that the biggest mistake that practitioners do, or that is going to make owners upset, is the fact of not recommending anything. They look at the mouth, they're like, yeah, it has calculus, and then they gloss over it, and then they don't say anything. And then when they do get them in after there's a terrible odor coming from the mouth, or if the teeth are fractured, and then they come in for the cleaning, and then they go home with 15 less teeth, that's what's going to make the owner mad, because it's like, you never said anything to me before about this. Why did my dog or cat lose 15 teeth now when it wasn't a priority? So if it's documented in the medical record that, yeah, there's calculus, we recommended dental cleaning, and you're telling and you're giving that recommendation to them, especially just starting out, they can choose to accept it or ignore it. But I think that I've had more clients upset of like, why didn't anyone say that we needed to do this earlier?
Being the only board certified dentist at Iowa State, how do you balance from being needed to it just being unsustainable for you?
I ask myself that question every day.
Oh, good.
It it's a very slippery slope. I think that for me, I feel like I can affect more change by teaching people how to do what I do. At least know, like, how do you extract teeth? Giving them and empowering them to keep that money in their clinics so that they can, um, you know, so that they can provide the care, and then they can maintain that revenue, and then only truly refer when it is something that goes beyond the extractions. I would say, even in general, 90% of what I do here is because of the fact that they don't actually need me. They need anesthesia, and they need someone who's going to be fast to do it. So most of my cases as of late really are because they're referred from general practitioners because of a slew of comorbidities, like the temporary pacemaker, or like the cardiac cases that we have. um, you know I do have a hard line in the fact that I do not believe that general practitioners, I don't care how much training you've had or how many wet labs you've gone to, I do truly feel, if I had a sword to die on, it would be the general practitioners should not be doing endodontic procedures. They should not be doing root canals. They should not be doing the vital pulp therapies. And because I've seen the tragedies that have come and referred when those things have been done inappropriately. Um, so that, I mean,
Who wants to do those? I
I
mean,
you would be
that,
surprised.
oh my gosh, woof! That's
Yeah,
like you telling me to go do a TPLO. No
right.
interest. Yeah,
Yep.
I'll move
And
on.
and yeah, no, so I think that would be the sword that I would die on. But most of the other things, dentistry assists, do them. Extraction of any tooth, do it. I think that those are the ones, as long as you feel comfortable. Now when we get to like the super unerupted, or like the little small breed dogs with unerupted teeth, yep, I get it. Send it to me, because it can be my headache, not your headache. Your mental health isn't worth that. So there are some, but I would say for the most part, that would be the thing that I see is that it's a slippery slope. So, I've talked with the department chair of like, I feel like I can do more good by teaching 150 students that we graduate and give them confidence and the ability so that Iowa State students can feel like that they can go out there, and if they're presented with a slab fracture of an upper fourth premolar, they've done it and they know the mechanics of what they need to do to get that out so that they can improve that quality of life for that patient.
Was there a boundary you had to learn the hard way as a clinician or as an educator?
Explain to me more. What do you mean? Is there a boundary?
Because I mean, that's the whole thing. You're sitting here going, I love to educate, I love to talk to clients, I love to do this and all that. But is there a time in your career where you're like, I really need to start setting boundaries so I can watch out for myself?
Ooh, that is almost not a question I want to answer. I'm a do as I say, not as I do. I am terrible at setting boundaries. I actually just before this podcast, oncology had come and asked me, and I am off clinics this week, which means that I'm supposed to be concentrating on creating lectures and writing manuscripts and doing all of that stuff right now. And I'm like, well, I guess I could probably do this on Wednesday after I do this and after I do that. So I'm not the best person to say that for. Or to write that hard line. I mean, I try, but I would say my technician is much better at setting the boundaries for me than I am. Or my husband says, he's doing Brenda management, so he tries to set some of those boundaries. So I think it is very hard. I think it is, it's one of those things where, even after, I don't even want to say 20 plus years of practice, it is still something that I struggle with. But at the end of the day, how I live my work life here, the thing that I try to have to remember is that I am completely replaceable here. But where I'm not replaceable is at home. And I need, I try to have better boundaries, or my husband tries to do his Brenda management to call me and be like, hey, it's 5:30. You need to come home and you need to, be with the kids and you need to, have some of that time, or go to dance practice and bedazzle some outfit. You need to do those things that also fill your cup. And, but ultimately it's, what it takes for me to, sleep at night. So sometimes that's, me calling clients on the way to, my daughter's dance rehearsal, or on the way to my son's basketball practice. I call clients and I try to do that, but I am not great at setting boundaries. I am not. I try to have everybody else do that. Everybody says that you're supposed to have a no man. And so I try to use some of my colleagues as my no man, because if I ask them, should I do this, they ultimately will always just say no. And then I really have to think about, okay, should I do that or should I actually not do that?
Dr. Brenda, don't do as I do, just do as I say.
That's exactly. It's 100% accurate, for sure. Yes.
Well, let's do some rapid fire really quick, and then we could close out. One dental myth you want eradicated today.
That if an animal is not eating, it is because of its teeth. That is never me. Never me. Never. Never. They are not eating because there is some other comorbidity. It is not because they have a bad tooth somewhere.
Okay. 100%. One skill that every GP has to master.
One skill that every GP has to matter. The ability to make a tension-free closure on no matter what it is, whether it is a wound, whether it is an extraction site, no matter what it is, but the ability to be able to create a tension-free closure so that you don't have your extraction sites unzip themselves and dehiss, or have your other incisions have problems and have to go to secondary intention healing.
One thing dentistry teaches you about yourself.
Ooh, that I do not have patience. That is probably the big thing. I always tell the students, you have to have patience. I don't have patience.
Oh,
So,
yes.
the
Hold the
dentistry.
elevator there until you get a little bit loose, and then
Yep,
you go to the
yep,
other
no
side.
wiggling, just do
Right.
that. So I would say having patience is probably the biggest thing. And I would also say we can always be humbled. And that, just because I think I got it all together doesn't always mean that I truly do have it all together, and that it's still a learning process, and we will forever be learning.
And to close this out, I always ask all my guests one irreplaceable truth that you could tell any early career professional, veterinary student, even people out in the profession right now, that would help protect their mental sanity, their emotional exhaustion, and their burnout potential.
One thing that I would say is just be kind to yourself. We're all going to make mistakes. That's why they call it science with practice. We this is going to be perpetually learning, so learn to forgive yourself, learn to try to let go of your defeat, and relish in your successes, whether that's, hey, I got a client out in 15 minutes for a vaccination, or whether it's like, I did my spay under 15 minutes, or whether it's, hey, I did it under 30 minutes now as opposed to 45. But be gracious with yourself, be kind to yourself, and always remember that there is a world outside of veterinary medicine. And surround yourself with people who fill your cup, and to make yourself to fill those needs, to recharge your battery outside of veterinary medicine.
Yeah, and I want to thank you. I know we've had issues getting together, but I'm so glad we got together and had this discussion because this is something that, as you always tell, you're the one who told me the 3 Ds of practice, right? Derm, diarrhea, and dentistry.
Yep.
Um, and the dentistry is the one that's the most. Yeah, I don't want to say it's the hardest one to convince clients of because they don't see the problem, quote unquote. Because diarrhea they do, the ear infection they do, the skin infection they do, but you show them calculus on the teeth, or they come in with, oh, my dog has such bad breath. You're like, oh, well, we need to do a dental, and they're like, no. Um,
Mhm.
so I mean, I'm very happy we had this discussion. I'm very happy to hear that even a board certified veterinary dentist does break roots.
Yep,
That is like a huge take home message for everyone. Now,
for
if any of
sure.
the listeners have any questions or would like to email you to ask you about a case, what's the best way to do so?
Best is email, which you can get at Iowa State. So it's just a portion of my name, BMULHER at iastate.edu.
Well, I want to thank you so much for being here today. This has really meant a lot. Yes, do not drink a Monster or have 3 cups of coffee before a big dental procedure because that will not. Those are counterintuitive when it comes to the patient's part, and it is
True.
patience, and it's and like I said, should not be intimidating. If you do want to learn how to do endodontics and stuff like that, do go get board certified because I think we do need more boarded dentists out there, veterinary dentists out there. There are definitely not enough of those. This is also a procedure when it comes to regular dental cleaning and regular extractions. You should have confidence in doing because you're going to be doing a lot of them. And you just, and again, no 2 cases are the same. So I want to thank you for being here. I want to thank the listeners for listening. If you do have any questions to my listeners, please just hit me up on any of the socials. If you can't get a hold of Dr. Brenda, I will. I will get a hold of her for you. And we might even have her back again and we can go over like a dental rads case. That would be fun, I think. So, everyone, thank you for listening and we'll talk to you next time.